Well, welcome everybody. Thank you so much for joining our Data to Drive Decisions webinar series today. We're very excited to have some great presenters with us here today, which I will introduce here in just a second. We're going to be talking about using data to understand physician practices and optimizing patient outcomes as a result of using data. Just a few little housekeeping and agenda items. We'll be visiting with NORC and AHRQ and talking about AHRQ's initiative to address gaps in current physician and physician practice data through the development of a research database that's nationwide that also used Colorado data. And then also talking with Icon Health, who investigates complexities of healthcare and opportunities to implement value stream mapping in order to improve patient outcomes and experiences, specifically in the orthopedic space. We'll have some time for questions and feedback from the participants, and just a few notes in terms of housekeeping. This session is being recorded. We will post it afterwards, and you'll get a notification that it is available when we have it posted and ready to go. So we will also share the slides. If anybody would like the slides retrospectively, those will be coming to you. And during this webinar today, we will be taking questions via the chat box, and feel free to post a question at any point in time. We'll be monitoring those. We may hold some of the questions till the formal feedback and questions at the end, but feel free if something jumps into your mind or you want a clarification, we might jump in and answer those as we go along. So we're very excited today to introduce our presenters. We have Herbert Wong from the Agency for Healthcare Research and Quality at AHRQ. He's the Director of Statistical Research and Methods. Jennifer Smith with NORC at the University of Chicago. She's the Principal Data Scientist. And we have Duncan Sibson, Icon Health co-founder and COO. My name is Carrie Frank. I forgot to introduce myself. I'm the Vice President of Communication and Marketing here at CIVHC. I've been here for a while, and it's so exciting to get to feature our change agents today and share stories about how the APCD is being used. So just a little bit about CIVHC, in case any of you joining today haven't heard of us and are joining our webinars for the first time. Our mission is to empower individuals, communities, and organizations. We have collaborative support services, and we provide healthcare information to advance the triple aim. So everything we do is to advance better health, better care, and lower costs. We are a nonprofit organization. We're independent and we're objective. And we really serve a variety of folks out there, both in Colorado and nationally. So we think of all of our partners as our change agents that are doing the hard work on the ground. Those are individuals, communities, and organizations, everybody working to make the consumer there in the middle. Everybody, Colorado is our main focus. And we're really striving to improve the lives of Coloradans. So we work with clinicians and hospitals. We'll be talking with some researchers today. We do a lot of work with researchers and state agencies, employers, nonprofits, and health plans. So really the gamut of stakeholders in the state and the nation. So we are going to be talking about data that has been used from the Colorado All-Payer Claims Database. And actually, we just updated this overview. We now have over 800 million total claims in the database, and that encompasses medical, pharmacy, and dental, and it's across Medicaid, Medicare, and all commercial payers. So if you look at the total across all of the years since 2013, we've had 44 payers in the database. We have around 38 right now that are doing annual submissions and monthly submissions between commercial, Medicare, and Medicaid, and it does encompass the vast majority of lives in Colorado. That's the total number of people that we've had, 8 million in the claims database over time. We have roughly over 5 million annually unique lives that are represented. So it's a very robust data set. And what we do with that is we provide both public and non-public data. So public data, we have a shop for care tool for consumers. We have also a lot of population health information like low value care and cost of care that is all available online, lots of data sets that you can download as well. So feel free to check out our website at civic.org. And then what we'll be talking about today is our non-public APCD process, so that we provide data sets and reports for change agents to conduct their own research, or we provide custom analyses to answer specific questions that folks might have that are looking to improve cost, quality, and health. So I'm going to go ahead and turn it over to our stars of the show today. And I believe I'm turning it over to Herbert Wong first. So thank you so much for being here, and I'll let you take it away.
Thank you very much. So thank you, Carrie, for that introduction. So again, my name is Herb Wong, and I am the Director of the Division for Statistical Research and Methods here at the Agency for Healthcare Research and Quality, also known as AHRQ. So for the next 20 minutes or so, Jen Smith with NORC and I will like to describe to you a new database that AHRQ has sponsored called the Physician and Physician Practice Research Database. Now, because I'm a big Star Wars fan, the naming of this database was intentional, so that the acronym of the database is called 3PRD. Okay, so that's the name of our database. And just by way of background, I am trained as an economist, and I have spent my career really conducting research and policy analysis, but more importantly, in the data development space as well. So like many people at AHRQ, the combination of conducting research and involvement in data development activities gives us a bit of advantage, I think, in building research database that is useful for the academic field. Now, for 3PRD, is really a part of a larger AHRQ initiative, which we call AHRQ Data Innovations. Now, AHRQ Data Innovation is really an effort that the agency has undertaken to identify existing data gaps and to build prototype databases to address those databases that we have uncovered. And so for today's presentation, I'm going to start off with just providing you with some motivation for this particular data development effort. And then I'm going to turn the floor over to Jen, who will provide you with an overview of how the database was in fact built. Next slide, please. So AHRQ is one of what they call 12 operating divisions within the U.S. Department of Health and Human Services. And AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, affordable, and to work with the U.S. Department of Health and Human Services and other partners to make sure that the evidence is understood and used. Now, AHRQ achieves its missions largely through funding and conducting healthcare research, and AHRQ funds research through grants, but it also conducts certain data initiatives through contracts. In addition to that, AHRQ has actually had a long history of database development and dissemination. The flagship data programs here at AHRQ includes the Medical Expenditure Panel Survey, also known as MEPS, and the Healthcare Cost and Utilization Project that is also known as HCUP. Next slide, please. So let me give you a sense of some motivation for this particular database. So over the last several years, there's been this growing recognition that the national healthcare environment has been really changing. There are new issues in healthcare delivery that is constantly emerging. And we began to recognize that policy analysts are trapped in the sense that they don't have the right database to properly address lots of these different issues that are emerging. So in general, there's this growing recognition that more data are in fact needed to inform public and private policy, especially address issues that are related to equity, health insurance coverage, healthcare markets, and competition. Now, 3PRD was particularly motivated by the COVID national emergency that took place back in March of 2020. As the COVID national emergency emerged, the U.S. Department of Health and Human Services was seeking information to help inform them of how best to implement the CARES Act relief funds that were to be distributed in a very quick fashion. The department actually approached AHRQ with many different requests for information. We were able to provide them with answers to many of those questions, particularly with the data sources that we had. And we were able to provide information to them on hospitals in particular. But really, a set of questions that emerged dealt with physician and physician practices. And we quickly recognized that we actually had very little information in that particular space. That to the department highlighted the fact that there were serious data gaps that the government, in fact, had to make quick decisions. Now, if you take a look at how healthcare expenditures are allocated in the US, roughly 32% of national healthcare expenditures falls within hospital care realm. The next category is actually on physician and clinical services, which represents about 20% of all healthcare expenditures. So in the fall of 2020, AHRQ made a conscious decision to invest some funds to explore what we can possibly do in the physician and physician practice space. And so that led to this particular effort, the physician practice database, or 3PRD. So that's how this project was really motivated. And so with that, I'm going to turn this over to Jen, who's going to describe to you how we, in fact, succeeded in fulfilling our mission to produce this database. Jen?
Thanks, Herb. So I am going to take you through all of the steps that we've done very briefly in order to create the 3PRD database. They span from our planning stage to data acquisition, which is where CIVHC and the Colorado APCD comes in, the processing that we did of the incoming data, building the 3PRD, testing the database that we built, and now to sharing our results with people such as yourselves. Next slide, please. So the first thing we did in the planning phase was we decided to conduct an environmental scan to evaluate the data. We wanted to know what kind of data sources were available, and we broke them down into three main categories. The first is data sources that contained information that was common to states. This comprised of data sources like NPES, which is the National Plan and Provider Enumeration System, which is the database where you could find NPIs for providers. The Federation of State Medical Board data and the AMA master file. We found sources for physician practices. One in particular that we used is the PACOS, which is the database that providers sign up with in order to be paid by CMS. We also looked at data sources that have information that is unique to states. And for this, there were two main sources that we identified that contain information unique to states. One is claims databases, and the other one is state medical board data. The reason why the claims databases are unique to states is because each state obviously has a different population. The data they collect, each APCD collects similar but different information regarding their population. How they store their data is slightly different, and obviously the policies within each state is different. So the data is slightly different. And then we also looked at other data sources, such as the Association of American Medical Colleges and AHRQ's Compendium of US Health Systems. Next slide. After we evaluated all of the data sources, we went into data acquisition stage. We ended up obtaining state medical board data for 21 different states. We conducted outreach to 7 states for their APCD data, and we ended up obtaining APCD data from 4 different states, Colorado being one of them. We also obtained the NPES, PACOS, and compendium information to help build out our databases. Next slide, please. During the process stage, this does not pertain directly to the APCD data. It mostly pertains to the state medical board data. As I in the next couple slides, I'll show, we use the APCD to append to the state medical board data. So what we needed to do was we needed to align all the state medical board information across all 13 states that comprise the 3 PRD, so that we could ensure that analysis could be conducted uniformly across all states. Here, we cleaned up names and addresses, we harmonized specialty information, and we adjudicated provider information. The 3 PRD, being a physician database, only contains information for medical doctors and doctors of osteopathic medicine. Therefore, we used information from both the APCD, CMS Medicare fee-for-service, and the state medical board data, as well as NPES and PACOS, to narrow down which providers actually held a doctorate in medicine degree. Finally, we linked the, oh, you're fine, you can go back. You can move forward. Finally, we linked all these data sets together. And in linking the data sets together, we confirmed the linkage using the Giroux-Winkler algorithm. So the first step, we linked the state medical board data to the NPES file using the state medical license number. Most state medical board data does not include an MPI, which would mean that we could not link it to APCD data. So we attached the MPI to the state medical board data, and then we pulled in the PACOS data, and this created a huge net of possible physicians that we could then adjudicate. Next slide, please. After the adjudication of that linked file, we ended up with what we call the core physician file. This is a file of providers that we are confident are physicians within the state. And this core physician file contains several key characteristics. We included a global 3 PRD provider ID in case of any PUF file being released later on, we would need to remove the NPI. We contained the license status. By this, I mean, do they have an active license, an expired license, a suspended license, so forth and so on. The license states, the physician name and sex. For certain states, we were able to obtain military affiliation, board certification, and medical school location. And then we also included our harmonized specialty information. Next slide. Once we did this process stage, we transitioned quickly into the building stage. For the building stage, we needed to finalize which 13 states we were going to build the database for. We developed physician characteristics from the claims data. We identified physician practice sites. And by a practice site for the 3 PRD, we're trying to triangulate where the service was provided. So it's not necessarily the organization that provided it, but we tried using the tax identification number, the organizational NPI, and the servicing zip code to kind of identify the location that the physician was providing the service at. And what's important here is not all APCDs have TIN. Colorado does, and so we were able to use this algorithm for Colorado. And then we developed physician practice characteristics from the claims data. So the final 13 states, we started with the 4 states that we were able to obtain APCD information from, and that included Arkansas, Colorado, Maryland, and Washington. Then we identified states that have APCD programs or were developing programs. And then finally, we rounded out the 13 states for geographical representativeness for the Southwest areas, border state of Arkansas, and then a frontier state. When we look to build the claims variables, we standardized the coding across all states, regardless of the source of the claims data. For Colorado, the source of claims includes the Colorado APCD information, plus the CMS Medicare fee-for-service data. Not all state APCDs provided us with Medicaid data. However, the Colorado 3PRD does include Medicaid data from the Colorado APCD. We thought that this was a better source of true information, as it would allow us to kind of see everything within the state APCD universe. Patient identifiers would be harmonized across the commercial populations and Medicare Advantage populations, rather than trying to pull in disparate information from the TMSIS data. And then, of course, for the Colorado 3PRD, we have information pertaining to the Medicare Advantage population and the commercial population as well. This slide looks at how we actually built the Colorado 3PRD file. We linked that core physician file that we created for Colorado to the state APCD claims and the Medicare fee-for-service claims. And we created a flag for actively practicing. Not all Colorado physicians we identified actively provided a service within the year that we were looking at. We created flags for whether they're billing to Medicare, Medicaid, or commercial population. We have minimum, average, and maximum number of patients seen in a month. This is to kind of give a idea of the distribution of number of patients. We also did it for number of claims submitted in a month. We wanted the researcher to be able to address questions of seasonality. We also identified the top 5 diagnoses of the patients served, the top 5 most provided services and procedures. And then we also included on the physician research file, the top 5 practice sites. Next slide, please. Because that slide had a bit small type, I pulled out some of the major variables from the physician side of the 3PRD. The 3PRD is actually made up of 2 files, the physician file and the practice file, and they are linkable. So we put the practice IDs on the physician variable side. Next slide. We did a similar process for the physician practice file. Here, we identified the practice sites. Each practice site has a practice ID. We included the organizational MPI and the zip code on the practice file, the number of 3PRD physicians associated with that practice, the most common specialty of the 3PRD physicians, and we also included the total number of providers at that practice site. This would give you a kind of an idea of how many nurse practitioners or physician's assistants would be also associated with the practice overall. Again, we have average patients and claims submitted in a month, and whether or not they're submitting to Medicare, Medicaid, or commercial payers. We also provide, on both the physician side and the practice side, we provide information for the patient panel and their demographics. Next slide, please. So for the practice variables, the patient panel demographics include percent of patients in different age groups, percent of the patient panel that's female, non-white, and Hispanic. We do the similar thing on the physician side. For the practice side, we also include whether the practice is primary care focused, whether they are focused on medical specialties or surgical specialty focused. And then we also indicate whether it's a hospital-based type of practice. Next slide. So once we built the 3PRD, we did some benchmarking, and we benchmarked the number of 3PRD physicians for Colorado against information found within the Association of American Medical Colleges Workforce Survey. So here you see that we identified a little over 22,000 physicians within Colorado. The workforce survey has about 17,000, so it's almost a 6,000 person difference. It's a difference about 34%. This is what we expected to see because not everyone within the Colorado 3 PRD is actively providing services. The Colorado APCD is what enriches that state medical board data with us being able to identify who actually provided a service and what type of service they provided. We also did some assessment of impact of cell suppression. Cells less than 10 had to be suppressed for different DUAs. And so we did an assessment of cell suppression within the 3 PRD. Next slide. We also conducted an analysis of outlier data. So this is what we looked at for the Colorado 3 PRD. We just basically did a straight univariate and did a visual inspection of the data to see if there were any variables that kind of stood out. We compared the maximum value of claims per month to the global mean and median of the population. And if someone stood out, then we dug a bit further. Next slide. So for Colorado, the top offender has a maximum number of 46,195 claims per month, which is highly unusual for one physician to be able to do within 1 month. The next closest 3 physicians had 8,000, 5,500, and 4,500 claims per month, respectively. The top offender is an internal medicine and geriatric medicine physician in Denver with a specialty in aging process and skills in diagnostic, therapeutic, and rehabilitative aspects. Their entity code was only of a practitioner, individual practitioner, but as we dug a bit further, we found out this person is associated with the Kaiser Colorado Permanente Medical Group, and they are the Vice President and Chief Quality Officer who is responsible for oversight of 1,200 plus physician group. Next slide, please. This type of scenario, so our final finding is that this type of scenario is similar to patterns that we're seeing in other states. In other words, there are certain individuals where it looks like they are over a large number of providers. And we do know that there are instances when a provider can bill under a different provider's NPI. And so we kind of dig into this and see, is this the type of person where that situation might be happening? And for Colorado, it does seem to be that this is what is going on, is that there are VP and a chief medical officer, and so their NPI might be associated with billing that's actually being performed by other providers within the group. Next slide. So there are 3 key elements of the 3 PRD. There is the physician file and the practice file, and they are linkable. There is a global provider ID, so it will be possible, even if NPI is not present on the file, it will be possible to do analysis for providers that may provide care across the state line. And we are able to answer key questions that AHRQ had posed to us initially with how many physicians in the state of Colorado have a license? What are the number of physicians with an active license that actively provide care? And the number of physicians with licenses that have recently expired, but perhaps during an event like the PHE, Colorado might have been able to call them back into service to provide care for populations where there wasn't enough provider network adequacy. Next slide. We have created 3 files for public distribution. We have created a public use file, or PUF. These are directories of physicians and physician practices, but they do not have any of the APCD data attached. We have created a restricted use file. These have limited variables from the APCD data. And then we have a geographic PUF, which has aggregated all information up to the zip code level, so we can provide more information, but at a higher level that would not impede against any type of disclosure situation.
Thank you so much, Jen and Herb. Appreciate all that, and what a lot of work you guys have done over the last couple of years. Holy moly, pulling all that together. I have just a quick question before we go, and just a reminder to folks, if you do have questions for our panelists, please type those into the chat. We can take them now or at the end. How would somebody go about getting access to the public use files? Where do those live?
Great question, Carrie. So we're about to wrap up, that is, conclude our project. So AHRQ is expecting the final data deliverables to arrive to us in mid-July. Sometime in August, late August, early September timeframe, is going to be a stage release. So the first release will be the public use file, the true PUF. Those do not require a data use agreement. And if you go to the AHRQ website under data, there should be a link that will get you to the right landing page on that. And there you can actually just download the data, again, in the August, September timeframe. On a parallel track, we will be working out a data use agreement where folks can potentially get what we call the restricted use files. And there we just want to be just a little bit extra careful, because we do have other data elements there that might be viewed as a bit more sensitive. And we want to make sure that people use it in a way that does not disclose the identity of any individuals, physicians, institutions, things of that nature. And it's used only for the purposes of research and aggregate statistical reporting. So I think the short answer is late August, early September, go to the AHRQ website under the data tab and probably look for AHRQ data innovations, and it'll be one of the links there.
Excellent. And a couple of questions from our folks who are listening in. Can you provide it at a county level in rural zip codes? Is it going to be available at that level? Do you know?
Go ahead, Herb.
No, I was going to let you answer that because you're a little bit more familiar with the data production than I was.
Right. So we opted to go with the zip code level because, as you said, in rural areas, zip codes can cross counties. So since we use the information of the zip code on the actual claim, from the claim, we opted to just roll it up to the zip code level. Obviously, how that happens county to county and how data is stored zip code versus county would change state by state. And under the scope of the current work, we decided to leave it at the zip code level, but we would appreciate the opportunity to extend that work to evaluate the data and make sure that it is reliable at the county level.
Great.
Although I don't know if that will happen, but yeah.
Another question, are you guys able to distinguish care delivered from non-physicians like APNs and PAs from that of physicians? And if so, does that change how you interpret the data?
So right now, the data, like the top 5 diagnosis codes, the top 5 procedure codes, those are all identified from the NPI. So if a nurse practitioner or a physician's assistant is billing under the MD's or DO's NPI, we have not been able to distinguish that. We started going down that road with one state, but how things were being billed became a bit tricky. So we would need to do additional study into the individual state policies and how they bill that and code that within the claims files in order to be able to tease that out. So at this point in time, the information is reflective of the physician's NPI. Although you can get some sort of sense of it if you are seeing astronomical numbers that are unrealistic for one person to do. And the practice has only one physician, but maybe 5 other non-physician practitioners.
Great, thank you. Couple other quick questions and then we'll turn it over to Duncan. Question about requiring, is there any national desire to require claims to contain the physical address of the service delivery? Right now, it seems claims frequently only contain the address of the billing organization. I know we collect place of service as well, but I'm not sure what you saw from other claims databases that you looked at.
Herb, I might let you take this one because this seems more of a policy type of question.
So it is a little bit of policy. So I will give it a crack. We actually thought really hard about this particular situation, and we are recognizing that billing information is of limited value. Location of the service matters quite a bit. And for some of these components, especially for the APCD data that we had, we actually tried to figure out the location of the practice based on where it's not billed, but where the services are in fact provided. Now, moving forward, since this is in fact a prototype, we recognize that lots of information is actually based on the billing site. And that's going to be something for us to try to sort out in the future, because from an analytic point of view, location is the desired data element, not the billing. And there might be some information out there, but it's hard for us to tease out at the moment. I think that is something that is aspirational for us to try to get at in the future. So great question, and that's something that we are clearly going to work at.
Great. In the interest of time, I'm going to save the last 2 questions for the end. I want to make sure we have plenty of time for Duncan, but thank you guys so much. Duncan, I will turn it over to you. Go for it. Thanks for being here.
Yeah, thank you. Thank you for having me. I'm Duncan Sibson, COO and co-founder of Icon Health. I've spent the last 15 years of my career in orthopedics. Originally began on the medical device side in product development, designing and manufacturing, and ultimately launching spine devices and joint replacement implants. And so spent a lot of time in the operating room with surgeons and their surgical staff across the nation, and observed a lot of variability in those operating rooms. And then prior to starting Icon Health, I also worked with an organization that was the largest awardee convener in Medicare's bundled payment program. And so at that scale, from a national perspective, saw hundreds of thousands of episodes per year, but importantly, the data underlying those episodes. And so ultimately started to see the things that I was observing in the operating room span out to a national level and happening across the nation in terms of the variability of care and outcomes and ultimately cost. And so it really created an impetus to start Icon Health. With that, if you could go to the next slide. Thank you. Thank you, CIVHC. First and foremost, just wanted to express my appreciation for what CIVHC has created, and specifically the Colorado APCD. On a number of fronts, I think what Colorado and CIVHC is doing is quite unique. You don't find APCDs in every state. They're difficult to create legislation around. They're difficult to stand up, and they're ultimately difficult to maintain, particularly at the level of quality that CIVHC has maintained their APCD database. The previous presenters talked a lot about the unique data elements that are available in the Colorado APCD that may not be available in others. And we're certainly finding that ourselves. So wanted to give just a big thank you in terms of really having what I would personally consider the best and most comprehensive APCD database out there, with really a robust data set that is well normalized and standardized, but not overly scrubbed either. And so that's, I think, a really important consideration when working with large data sets and ultimately trying to derive insights that create an environment to push forward, again, the civic triple aim of better health, better care, and lower cost. So again, just wanted to say that and to emphasize that. So with that, I'll jump in. And my first point here is this is transactions on the New York Stock Exchange, just an old, I think from a 1939 New York Times paper. And my point here is what I'm observing in healthcare right now, particularly around data and where we're going, is feels very analogous to the personal finance revolution that really began in the 1950s, where data in terms of the stock market, the bond market, and really how people manage their own personal finances was originally started with the organization and publication of data, but then the distribution, because early on, you think about it, in the 50s, consumers had little personal finance knowledge and were not great consumers of finance. And so they had either pension funds managing their retirement investments or Social Security to rely on. And so there was an element of paternalistic management of people's finances, and that started to change when information became more available. 401k, new products such as credit cards became available to individuals, and ultimately new products and new organizations started catering to individuals. You had Charles Schwab, you had Merrill Lynch, and what is important, or what is kind of the distinction or the analog here, is data is critical. Structured data is really the next critical step. But then there needs to be an interpretation layer and ultimately an expert to help a consumer of either personal finance or a consumer of healthcare interpret data that at first can be very confusing and very difficult to ascertain the noise from the signals. And I think that's kind of where we are now. We're on the cusp of a very similar, I think, revolution within healthcare, where people will become increasing consumers of their own healthcare and better educated, such that they can determine who to go to, what type of provider to go to, and ultimately to be able to measure and determine outcomes and cost. And so you're starting also to see a flood of great data into the marketplace. Again, congratulations and kudos to Civic, but you also see it at the national level from Medicare in terms of these programs, these value-based programs coming out of CMMI and releasing data sets alongside it. The LDS data from Medicare, you see other states participating in APCDs, but now you also start to see rules and federal regulations around price transparency. And so as this data floods the market, it needs to be normalized and structured. But then I think the critical component is an interpretive layer until people become more familiar with consuming this type of information. Next slide, please. So if you look at Mia's journey here, or really any typical patient journey within orthopedics, Mia has back pain, and not only are there multiple points of entry into our current healthcare system. Mia could enter through an emergency department. She could go to her primary care physician. She can jump directly to a specialist. But ultimately, how Mia or a consumer of healthcare navigates through their own personal journey or their own personal orthopedic ailment is highly variable, and highly variable as evidenced by the data and information out there, such as, again, the Colorado APCD. And so Mia can journey and venture into a specialist office and ultimately be given a course of therapy, which can include physical therapy, injections, durable medical equipment, ultimately diagnostic imaging and or surgery, and then post-operative rehab to bring her back to health. But specialist care in the United States is largely uncoordinated, very expensive, and oftentimes leads to a poor experience because patients are left up to their own devices to determine where and how to navigate the healthcare system. Unfortunately, there's not a lot of resources out there to guide someone completely through the continuum of care. And instead, what happens is you find kind of these nodes on a network, or these spot interactions that have very little connectivity between them. And so one of the opportunities ahead of us in healthcare is, how do we leverage data to better understand these patient journeys, but more importantly, how we understand an optimal patient journey, and what frankly that means from a total cost of care perspective, but also a value-based care perspective, meaning outcomes over cost. And so just a quick rattling of some stats here. 44% of patients hit a dead end in their journey and stop, even though they haven't gotten back to recovery or thriving. 50% of patients are confused. They don't know what steps to take next. They, quite frankly, don't know what just happened. And there's a general level of confusion associated with entering the healthcare system. 24% of physician services are duplicative. So there's oftentimes a lot of, unfortunately, unnecessary care, but also duplicative care because of a lack of coordination or information sharing or exchange. And so again, with the advent of more information becoming available in the system, another great advance in healthcare is the interoperability of EHRs and other health information systems. And so there's certainly an opportunity on that front. And then 61% of self-referrals get it wrong. So if you're a patient suffering from an orthopedic condition or a muscle, bone, and joint condition, oftentimes you skip right past the primary care physician and go into a specialist. And that may be an unnecessary step, or you may be going to an ED when it's quite possible that a specialist visit or a primary care visit would be a more optimal first step. And that can also increase cost and unnecessary care into the system. Next slide, please. So, what can be a solution in this space? Really a personalized and comprehensive orthopedic benefit management, which is what Icon Health is. And so as you look at orthopedics, it typically accounts for 17 to 20% of overall medical spend, if you think about orthopedics comprehensively as a patient experiences it. So meaning not just the surgeon for a hip or knee replacement, not just the facility or the hospital that a patient may go to, but all of the ancillary services that are associated with an orthopedic disease state. So again, the physical therapy, the DME, the injections, the diagnostic imaging, rehab services, et cetera. And so it's a very large specialist area. And so what Icon does is we partner with employers, payers, and ultimately providers to really drive forward better outcomes for patients that we engage and ultimately navigate. And what that looks like is really around this concept of right time, right care, and right setting. And so first and foremost is to be able to proactively engage people early in their life cycle of orthopedics. So when that first diagnosis happens, or conditions suggest, the health risk assessment suggests that patients may be suffering from an orthopedic condition, to be able to engage a member timely and in a manner that gets them involved in their own care. What Icon offers is we are staffed with orthopedic experts that are able to connect with patients and ultimately provide a virtual consult and an ortho expert to be assigned to them throughout their journey of care. And that really means all the way through each of those disparate steps or individual steps through specialist providers or primary care or all of the necessary services to get them back to recovery or thriving, or back to the functional baseline. And so what happens in, if you go back one, thank you. What happens in that assessment is really, uncovering the underlying condition, uncovering care gaps, being able to identify and provide education such that there's shared decision-making in the process, but then to guide the patient throughout their care journey. And so that can come in really three different ways, or three different segments of care, one of which is conservative care, when and where a patient is appropriate to and be provided conservative care. Can we do something remotely, like home exercise plans, or very minimal but effective of care in terms of getting them back to, again, the functional baseline? But when and where kind of the other two branches of the opportunity open up is a person a surgical candidate, or are they at potential risk of needing a surgery? And so how do you navigate and ensure that you're setting that patient up for success as they navigate through? And that's really part of this guidance, and then alignment with ICON's providers of excellence, and then ultimately getting to that thriving or guided recovery. And at the end of the day, being able to measure the patient-reported outcomes, the total cost of care, the reduction of adverse events, and surgical outcomes and surgical utilization. So if you go to the next slide, how do you do that? One of the key components is working with excellent providers in network. And so this is just a sample of how we think of the world, but this concept of providers of excellence and individuals, again, within the healthcare ecosystem. So this is just a quick graph of looking at total hip arthroplasty surgeons at Denver area facilities. And on the the vertical axis, you have an outcomes index, and then on the x-axis, you have an efficiency index. And so the concept here is, how do we leverage data to ultimately tag providers with the total hip arthroplasty cases that they've done within a geographic area? How do we then measure the outcomes across the spectrum? And we ultimately take in over 300 metrics into a regression model. Use that model to generate an observed over expected look at each of the individual physicians, and then compare them to their peers within a geographic area. So you're starting to match up and understand how physicians play from both an outcomes perspective, but also an efficiency perspective. How efficient are they with healthcare utilization and ultimately cost, and ultimately the combination of the two is where you come to value. So the shaded green in the highlight are these top quintile physicians, both from a outcomes and efficiency perspective. And so as you look at it and going through the list of considerations, you have, again, you want a geographic bound to how you're looking at the data, because it's important as a patient experiences their own healthcare. You don't want them traveling out of state or significant distances to get to great providers. You want to look at specialty, and it's not just taxonomy. Are they an orthopedic surgeon, but rather specifically, are they a hip replacement surgeon, or a knee replacement surgeon, or a spine surgeon, or a shoulder surgeon? And so what is their specialty as identified by the types of procedures that they do and that they're active on? And then again, risk adjusting their experience to the patients that they've seen. So understanding and ensuring that they're not unfairly penalized for seeing a higher risk cohort of patients. And then the costs and the quality are ultimately factored into that. So if you go to the next slide. So this is just a couple of MSK diagnosis, but as you start to put these elements together and work with providers of excellence, what happens is you can really change the course of care to be more value-based, or really driving towards better outcomes and better cost. And that's across the spectrum of care. So you can see that surgery, of course, makes up a large portion of really any major orthopedic condition. But there are significant opportunities within diagnostic imaging, the DME, implants and supplies, E&M or evaluation and management, office visits, physical therapy, drugs and RX, and then ED and urgent care. And so what we've done is gone in and identified opportunities where currently in the Colorado data set, we would consider these, unmanaged diagnosis cohorts, but what is the opportunity to drive ultimately savings while maintaining or improving outcomes? And so there's a substantial opportunity within that. And then just aggregating or expanding back out, you can look at Colorado's data set from a commercial MSK or orthopedic claims by category. As you categorize the costs associated with a orthopedic diagnosis, you're getting to massive amounts of spend, $1.4 billion, and really opportunities within each of these categories to drive and to navigate towards lower costs across the board. Thank you.
Thank you so much, Duncan. That's excellent, bringing it down to the patient level. I have a quick question for you. Is ICON partnering directly with the orthopedic practices or with payers or a little bit of both? How does it exactly work?
It's a great question. So the answer is both. And it's from my perspective, it's important to do both because there needs to be connective tissue, particularly around the education, uplifting, and sharing of data with provider practices. Physicians, from my experience, and particularly surgeons, are hungry for information to understand where they stand and ultimately what their opportunities are to improve care. And so by having tighter and better collaboration between payers and providers, there's certainly an opportunity to get to great synergies that benefit both sides. We also work with employers in this because as a large purchaser of healthcare across the nation, it's important to bring employers into these conversations to ensure that all sides are working towards their employees and ultimately the patients that are accessing the healthcare system.
Thank you. And a reminder for folks, we do have about 4 minutes for questions and for our panelists. So please feel free to chat in the chat box. And I know we have a couple that we skipped over for Herb and Jen. So I'll go back to those while people are adding some additional questions they may have. One is the Kaiser erroneous billing that you guys identified that was assigned to the C-suite. Is that a billing practice within regulatory compliance from what you guys have investigated? And the comment was it's hard to improve the system with provider data like these.
So I can give it a crack, Jen. So I think the most important thing to remember is that claims data is actually designed for a totally different purpose, and that is billing. And to a large extent, state APCDs such as CIVHC leverage the fact that these databases exist, and we want to use it for different purposes, such as public health, policy analysis, and things like that. So to get right to the question, I guess, is that I think that an entity like Kaiser, eventually they do what they do, they get paid, and they might not be so, inclined to kind of get it right in terms of the exact assignment. One of the things that, I think that both for CIVHC and AHRQ, we're not regulatory bodies, so we cannot do enforcement. I don't even know what the regulation is in terms of that. So I think that from our perspective, the best that we can do is to understand what the data that we have, what it is and what it is not. And is it good enough for whatever analysis that we are seeking to do? And it's fundamentally to understand where those shortcomings might be. So that's not a great answer for you, but I guess it is an answer.
If I can add one thing to that, I wouldn't use the term erroneous billing because it may be the billing that is fully in line with not only regulation, but also with the entity. So Kaiser, if I'm remembering correctly, they pay a salary to their physicians, which is a different model than other places might have. So it is important for Kaiser to recoup the money so that then they can pay the salaries. Another place we're seeing this is for health departments that give out services. So the health department needs to recoup their money because they hire directly to the provider. So my only comment there would be I wouldn't necessarily assume that it was erroneous, but maybe reflective of the policies and regulations underneath.
Thank you. Another question, was there any calibration done against a practice's claims? For example, identifying the % claims missing from the data set and the impact to the analysis?
I could give it a crack too, Jen.
For it,
and then, one of the things I would say is that's actually a terrific question, and it gets at the whole issue of using data sets and trying to produce different metrics that kind of come across. This is actually quite a novel use that we have deployed in terms of this, and it's actually the first set of information that's even in this particular space. Now, With that said, I think that the question is actually quite important, and it gets at this issue of how is it that you begin to think about quality control? Does it pass a face validity? Are there other data sources out there that you can in fact benchmark? Right? And the short answer at this point, I think it's really difficult to find those other benchmarks. There are ways in which we can start to do that. For example, we know, for instance, that CMS collects a heck of a lot of information because they are a major payer. And do they happen to have information, at least in the Medicare population space, that we can do some sort of assessment using the other sources of data? So it's a long road to figure out that quality control component. And we have to think really hard about other different sources in which we can make, frankly, try to make apples to apples comparison to see how good our data metrics are.
Thank you. So we're out of time. I think we could probably hang out together and answer your questions and chat forever, but we'll give people respect and give them their day back. Just a quick reminder, we do hold these webinars on a monthly basis, and our next webinar is July 21st at 12. And we're going to be talking about what we're seeing in the data in terms of alternative payment models and how it's being used to address primary care and enhance primary care services by encouraging payers and practices to adopt alternative payment models for primary care specifically. So we'll be presenting alongside the Division of Insurance, and we will be sending out information shortly to register for that event. And I just want to thank Duncan and Jen and Herb. Thank you guys so much for all the great information, and really appreciate your time and expertise and all of the work you're doing to improve healthcare. We appreciate you guys, and everybody on the call, have a great afternoon, and we'll talk soon. Thanks so much.
Thank you. Take care.
Thank you, Carrie.
Take care.
Thank you.
Bye-bye.